Welcome back. Joining me now from New York to talk about the Ebola vaccine and how to stop its spread is epidemiologist Dr. Stephen Morse, and from Tennessee, Dr. Jim Crowe, Jr., Director of the Vanderbilt Vaccine Center. Gentlemen, thank you for being on the program.
Thank you. Glad to be with you.
Jim, let me begin with you. How soon can people expect a vaccine?
Well, vaccines have been in development for the last couple of years, and they were already ready to push out into clinical trials, but those have been expedited. So we're already seeing early vaccines being tested in safety trials in the United States, the UK, and in West Africa already.
Stephen, a lot of people are wondering if this Ebola epidemic had happened in UK or United States, we would have seen a vaccine a lot sooner. Your thoughts on that?
Well, if it had happened a few years ago, it takes several years to develop a vaccine and then to go through the testing. And right now it's being accelerated. And then obviously to be able to make enough to protect the population. So I think that part of it is the fact that it was in the tropics and in poor countries, but part of it is that the market for the vaccine is very uncertain, and it's taken time to develop it.
What do you mean by uncertain?
Well, Ebola outbreaks in the past, this one is extremely unusual in that it's large and involves several different countries. Most Ebola, in fact, all Ebola outbreaks in the past have usually been sporadic, unpredictable, and in rural areas with generally not very large populations that are also forested areas. So it's very hard to know who the target group is, who should be getting the vaccine. And since it hasn't been that prevalent, although it's a terrible disease, it's been very sporadic in the past with relatively small numbers compared to this one. There didn't seem to be much call for giving it to everyone except perhaps travelers and healthcare workers.
Gentlemen, let me get to the drug ZMapp. So far, it's saved the lives of two American Ebola patients. It seems like they've run out of ZMapp. Do you find that unusual, and can we expect to see more of it? And how much confidence do you have in this drug? Jim, let me begin with you.
Well, these patients were treated with the drug and they recovered, but we're not for certain at this point whether the drug contributed to that or not. So I think at this time we don't really know if it works. Okay. It needs to be tested in a way where we can determine if it does or doesn't work. The drug itself was just being prepared for early studies, and it was not really being manufactured at scale to distribute, so that's why there weren't many doses.
Stephen, your thoughts?
No, I would definitely agree with that. It certainly is an interesting drug that looks very promising, but there haven't been enough experiences with it to know exactly how useful it is and when it's best used. And it wasn't really, I don't think anyone expected that there would be such an immediate use for it. The process by which it's made takes some time. It's in genetically engineered tobacco, so you have to grow the tobacco and then extract the ZMapp product from an extract of the leaves. So it will take some time to make, but it should be fairly easy to scale up once they grow enough plants and start making it.
Jim, you've been saying a prototype drug or vaccine that worked in animals often encountered biotech valley of death. Can you explain that?
Well, vaccine development is quite expensive over time. The typical vaccine that you'll see being universally used in children during childhood immunization programs might cost $1 billion or $1.5 billion. And so resources are limited, and people have to commit those large-scale resources to things that are intended for universal use. And when you have smaller targets or drugs for smaller groups of people, like an Ebola vaccine, it's not clear who would invest that kind of money along the way. I think I give credit to the U.S. Department of Defense and the National Institutes of Health, who have been investing in vaccine development along the way for Ebola virus, and that's why we have the candidate vaccines and drugs that we do have, because of sort of a steady foundational funding, but it really wasn't scaled to bring a drug to market very rapidly.
Stephen, before I ask you my next question, do you agree with what Jim just said?
Oh, definitely. You know, there is an economic issue with any of these new products, and unless they're made by very large companies with very deep pockets who have a desire to do it, you know, it is very difficult for a new startup, for example, to introduce new products. That valley of death you spoke of. So I definitely agree with that.
Stephen, how long do you think it will take us to curb the Ebola crisis in West Africa? A lot of people have lost their lives to this deadly outbreak.
Yes, and I think that that will partly depend on how many volunteers are available. We're worried certainly that the attention now in places like New York, the possibility of quarantines and so on, even if they're perhaps lifted at this point, might discourage many volunteers who already have heard enough about the potential dangers. But it's very important to get people on the ground there. And of course, having a vaccine will be very valuable to try to get to the next group that might otherwise be at risk for the disease and stop the progression at that stage.
Jim, you just came back from an important meeting on Ebola in Europe. How close are we to an effective, viable vaccine? Would you put it in weeks, months, or years?
Well, just to comment about the current epidemic, we're most likely to hit the tipping point to turn this around, not with vaccines or drugs that are in development, but with public health measures, taking care of the patients, identifying them early with rapid diagnostics and keeping them from exposing others. So it's not likely that we're going to get vaccines and drugs moved fast enough to be the tipping point in this epidemic. That's more of a public health issue. But, you know, we're getting these things ready for the next outbreak, or if these public health measures fail over the next probably 6 to 12 months. So the vaccines that are being tested now, they're just being looked at for safety. We won't even know if they'll have any effect or be working for months, clearly, if not a year or two.
Stephen, do you think mandatory quarantine is necessary, you know, especially for healthcare workers when they come back from West Africa?
Well, in general, I think that's probably not targeting the group that most needs the attention, because most healthcare workers, I think, recognize their potential exposure. They can generally be relied upon to follow instructions, and if they're given proper instructions, I think they will monitor themselves carefully. And generally, we know where to find them. They're not generally people who have suddenly come out of a foreign country and whose whereabouts we don't know. Of course, it's much more difficult to talk about quarantine for people coming in from the affected countries, and that is very, in many ways, going to be very impractical. So I think the most important thing is really being able to identify those who may have or may have signs of the disease either when they come in, or more importantly, as in the case of our first imported example, that for Mr. Duncan in Dallas, those who may be developing it later. And so the clinicians also have to be informed about how to recognize Ebola.
And it seems there's so much fear about this disease, sometimes even wrong information out there just amongst people talking about their concern. I just want to make one point clear. Both of you still believe that this disease does not spread until the person has fever and is showing signs that person is symptomatic.
Yeah, I think even our experience in the United States so far, you see very symptomatic cases with copious vomiting and diarrhea, and people who were exposed to that are at risk. And all the other cases that have been considered contacts, we don't see transmission from people prior to symptoms. So all of our experience that we're having right now confirms what we've seen in the previous outbreaks in the epidemiology in West Africa, that it's really the symptomatic people who transmit.
All right, thank you so much. Dr. Jim Crowe joining us from Nashville, and Stephen Morse joining us from New York City. Thank you so much.
Thank you.
Thank you.
And that's it for this edition of The Heat. We'd love to hear from you, so please send us your questions, comments, and story ideas to theheat@cctv-america.com. And we'd like to continue the conversation on social media. Share your thoughts and comments on our Facebook page and on website, cctv-america.com. I'm Asiye Namdar in for Anna Naidu in Washington, D.C. Thank you for watching.